Professor. It's my honor, it's my pleasure to be here finally, and it's my first time in Egypt. It's my first time in Cairo as well, and now I have a difficult task. Actually, if you talk following Blake Papson, what can you do? It's difficult. I'd like to share with you some of my experience with single-sided deafness. So we're looking on something different. On the other hand, I was so pleased that Blake presented data that I felt but did not calculate already. I said, we have this newborn hearing screening, and where are they? Where are the young kids? This is one development, but there's another development at the same time. As we do not have a problem in funding bilateral implants, what I see in the very young children is that all parents nowadays, if they get to the clinic, they want bilateral simultaneous implants. Like it's totally different, like let me say 5-6 years ago even, when they said, oh, we would like to go for one implant first and then see what happens and go for a second implant. Nowadays, they say, no, if there's an indication, we want 2 implants right now. And so that means that in Freiburg, within the last year, for example, we had not a single case where we did a unilateral implant in an early bilateral deaf child. All of them received simultaneous bilateral ones. And I also agree that we have to be very careful in surgery. There were also several different points that I will come back to within my presentation. And I would like to talk a little bit about binaural hearing and the effects of 2 ears. What are the effects? Now, the advantage that we have, if we have 2 ears, is that we can use binaural summation, we can use binaural release for masking, the squelch effect, or I would say the central noise reduction system, and the head shadow effect, which is a purely physical effect. Now, when I started my education, single-sided deafness was not a point. There was just no treatment available, and you just found a single-sided deafness, and just that was it. That was all. There was no therapy available. Then conventional hearing aids were used as cross-hearing aids, which means contralateral routing of signals. So the noise was brought to the normal hearing ear, but this is also only pseudo-stereophonic auditory rehabilitation. Then bone-anchored hearing systems were used for the first time in single-sided deafness as cross-hearing aids, just a little bit more elegant maybe. So this was in the early 2000s. And then cochlear implantation was used for auditory rehabilitation in unilateral deafness. And we have heard today Paul van der Heining, and he actually was the first one to do it. And they did it not for the auditory rehabilitation purpose, but for tinnitus reduction. This was the main purpose initially. And by the way, they found, oh, there's some auditory rehabilitation possible if we use a cochlear implant in unilateral deafness. And then Susan Arndt in our clinic led a huge study and really developed criteria for implantation and postoperative evaluation, and we're following up, and I would like to show you some results of these studies. The evaluation of the patients is just the same like in other cochlear implant patients with a real intensive focus on the MRI, and I will tell you later on why that is. We need objective audiometry, we need maybe a neuropediatric evaluation, and we have to think about other developmental disorders if they are known or suspected. We need an extensive counseling of these patients because there are alternative treatments. No treatment, bone-anchored hearing system, cross-hearing aids, or cochlear implants. So we have to really sure patients understand what a cochlear implant surgery means in their individual case. And the rehabilitation process following cochlear implants in single-sided deafness also needs time. It needs not only weeks or months, but years. We have to make sure that patients and parents understand the need for rehabilitation. And we can also say from our first patients, where patients were not willing to use the implant or to go to rehabilitation or speech therapy training, the results were worse. And only if we intensified the training process, the results were better. And now they're just in the same rehabilitation process like all the other patients in our clinic. I would like to show you first results of adults, later of children. In the adults group, we make a little bit of differentiation in between a true single-sided deaf patient. What is it? What is a true single-sided patient? He has a normal hearing up to a max of 30 dB on the good ear and is within the criteria of a cochlear implant on the other side, as you can see here on the left side. This is the worst ear, this is a good ear, and they're all better than 30 dB. And then there's another group that have not been candidates, but might be candidates for a cochlear implant in the future if we look at our old criteria. They have a deafness on one side, and they are worse than the single-sided deaf group. They have a hearing impairment here, but they are better than 60 dB. So actually, they never qualified for a cochlear implant in the past. The question is, first of all, can single-sided deaf patients integrate cochlear implants, electrical stimulation, and normal hearing? And the second question is, can asymmetric hearing loss, AHL patients, integrate hearing and stimulation with a hearing aid and electrical stimulation if the asymmetry is still huge? Now, the tests that we use to find out about benefit in single-sided patients are pretty easy. All clinics have a little bit different tests, but what they try to do is they try to separate or combine a signal and a noise to the ear, both together, for example, from the front, like in this situation, or with speech coming to the deaf ear and noise coming to the normal hearing ear, or vice versa, noise coming to the deaf ear and speech coming to the normal hearing ear. Here we can use different kinds of speech tests. We use a German adaptive Oldenburg sentence test to find about 50% speech understanding in noise. And we look at the speech reception threshold. So we find a signal-to-noise ratio where we find 50% speech understanding. This is a difficult test. You should try it yourself, even if you're normal hearing. It's not easy to perform. What do we test with this speech and noise informations is the head shadow effect, which is purely physical, and it means that, for example, speech has to come to the normal hearing ear, which is also at the same time receiving the noise from the same side. So we have differences in intensity, differences in timing, for example, and this is head shadow. We have both from the front, so we test for summation. Summation enables us to hear something louder if we can use two ears, and it's a binaural central processing. And here we have the squelch, the central noise reduction, where the noise is coming here to the deaf side, speech comes to the normal hearing side. Now, another test that we also do in all these groups of patients is localization abilities. Because if you ask people, what is the problem? Why couldn't I use a monocle? Why am I using normal glasses? It's about depth, and it's about, again? I don't understand. No, again? Yes, it's my vision. But the same is true for hearing, you know? So if the problem is if I have only one ear, I have problems with noise, everybody knows that, but I have another problem. The stereophonic hearing enables us to localize, to estimate distances. And this is the same like when I use glasses. So what we're looking for in our tests also is localization. And that we can do in different setups. We use the setups with 7 loudspeakers, with Oldenburg sentences, with a lever randomization, and also that can be calculated then for the localization error, for example. Now, what are the results of these patients? What do we find? In adult patients with unilateral deafness, 48 patients, 12 months experience at least. And what we see here are the results, and the gray ones are without any help, without a cochlear implant. The red one here is with cochlear implant. So if we look for the head shadow effect, we see, of course, that they can overcome the head shadow, purely physical, with a cochlear implant, and we see a summation effect. Here in the squelch, we see no difference in performance. And the more negative it is, the better the results are, the better the signal-to-noise ratio for the patient. This actually is not bad news, it's good news. Why? In this situation, the noise comes to the cochlear implant ear. So the noise is heard. And here the speech comes to the normal hearing ear. And the question is if the noise is disturbing the speech understanding. No, it doesn't. Good news. Central processing is working. And here we have the localization results, and you see the significant improvement. And the smaller it is, the better it is, the smaller is the localization error. And you can see that patients with a cochlear implant and a normal hearing ear are able, again, to use localization. What's about the patients that have asymmetric hearing loss? So they have a little bit of hearing loss, but not enough, and they have a deaf ear on the other side. And basically, it's the same results. And interestingly, they also show significant advantages here. We can see really the squelch effect in this group for the first time. Not only are they not disturbed by the noise that comes to the cochlear implant ear, but they actually can improve their speech understanding. They have a better signal-to-noise ratio for this group. And the same is true if you look at the subjective outcome. So does it help you if you have a cochlear implant and you have a unilateral deafness? Are you using it? You can look at the data logging, for example, and these patients use their implant 8 hours a day, while totally bilateral deaf patients use the implant 12 hours a day in a mean. What does it mean? Actually, they use the implant in their waking hours when they're working. They don't need it in the morning to say, darling, I would like to have a coffee. But they use it when they're working. So in the working hours, which is 8 hours per day, these patients use their implant. And subjectively in the SSQ test, you see in both groups the advantages and the improvement for speech and localization abilities. And even here you see a trend in the AHL group for the quality of hearing, which I think is quite interesting. Now let's compare these results with other possibilities, because I said they have to be counseled that there are possible rehabilitation like cross hearing aids or no therapy or bone conduction hearing aids. Now, if we compare the unaided situation, the cross situation, with a bone-anchored hearing solution with a cochlear implant, for the same tests I showed you, and these are all 21 adult patients where we could compare that on the long term, 12 months, what you can see is that they have huge advantages for head shadow, of course, for summation, and here also for the squelch and for localization. So interesting is this part of this slide where you can see that the cross hearing aid and the bone conducted solution in that situation are disadvantages. They have huge disadvantages. You see that with a cochlear implant, you have a better signal-to-noise ratio, so you improve. And in this situation, by using a cross or a bone-anchored solution, the noise is transferred to the normal hearing ear at the same time. So the normal hearing ear has the information of speech and noise at the same time, which leads to a reduction of speech understanding. The only situation where bone-anchored and cross have some superiority or some improvement is here the physical head shadow effect, but it's not binaural rehabilitation. Same is true for the AHL patients. Now let's have a look at the children. Children are a totally different story when compared to the adults if we talk about unilateral deafness. They have a need of additional educational assistance, that's well known. They have an increased need for speech therapy, although they have a normal hearing ear. They may have problems with self-esteem, hearing fatigue, negative effect on academic success. Should we give them an implant? There are still voices that say, no, we should not. This is 2 publications from Probst from Zurich. He was a long-time head of ENT, otolaryngology, in the University Clinic of Zurich. And he said that we are creating patients by performing auditory rehabilitation in unilateral deafness in children. And they need the opportunity, they need time to develop compensation strategies. We might stigmatize them by giving them an implant. They might become a non-user. Yes, they might. And he asked for a critical observation of long-term results. And I think this is the only point I would agree with. We need a critical observation. If you look at the time and the need for compensation strategies, I would like to refer once again to Blake, who showed us how important early implantation is. And why shouldn't it be the same in unilateral deaf children? Why should it be different? I don't think so. Now, if you look at our group of children that we see or have seen in Freiburg, we have evaluated a number of patients with unilateral deafness. These are the congenital ones, the acquired are trauma, meningitis, large aqueductus, and so on. Interesting is a group of congenital unilateral SSDs, those children that you might find with newborn hearing screening. And here we have, in this group, we had 13 children with auditory nerve dysplasia, cochlear nerve dysplasia, which is quite important. Others are either unknown, genetic, auditory neuropathy, ototoxic, and CMV. So we have two important points in the slides. CMV, we heard about it. Important because we can have a progression of hearing loss in the good ear later on, and we might miss it. And they're extremely interesting and important candidates for implants. And then we have the CNDs. And CND is quite a big point. Up to 50%, 50, half of the children with congenital unilateral deafness will not qualify for a cochlear implant. They won't, because they do not have an auditory nerve, as you can see here. CT looks normal, and I agree totally with Blake. We have to think about radiation exposure, and we try to reduce as much as possible radiation exposure. So MRI is the important point where we have to look at. And here you can see on the one hand, facial nerve, we can see vestibular superior, inferior, and the cochlear nerve, and here, just nothing. 50% have no auditory nerve, and we don't know why that is, and they do not qualify. I would like to show you some results. These are 12 months results in children with acquired deafness, acquired. And here we see basically we did the same tests, which is difficult in these children because the age heterogeneity is huge in our population and children. But still, we did it here with an Oldenburg sentence test in 9 children, and you see the same effects and the same advantages in using an implant in acquired deafness. What about children with congenital unilateral deafness? A little bit more a different story. Why is that? Because the duration of deafness is the age at implantation, right? Yes. So if I have a child age 5 with a congenital, the duration of deafness is 5 years, right? So we have here a group of children where we have also 12 months data and more, at least 12 months. Age at implantation, 1 year, 9 months, up to 13 years and 10 months. So it's a heterogeneous group. What would we see of etiology? A lot of CMVs here. Unknown, hypoxia, enlarged vestibular aqueduct, ototoxic. All of them had a totally normal hearing on the other sides. Now, what's about the results? I will show you, don't worry about this slide. If we look at the speech discrimination and the usage, something is popping up, and this is here, patient number 5, age at surgery 4.4, non-user. And why is that? 20% speech understanding in an adapted children test is not very much. And when we really look at the details here of the speech understanding, let me say in the last column here, which is adapted monosyllable tests, excellent results on the young group. Here, a mixed group aged between 4 and 5, from non-user to 80%.
Dear doctor, your time is up.
Thank you. And 45%. In here, we have the last group older than 5, 40%, 10% non-user. So these are very mixed results. And if I try to, can I get the next slide, please? I have time. I have time. Thank you so much, Professor. The point is, I'm nearly at the end. I'm not so exact like Black, I'm sorry, but I nearly got it. The point is, the results in congenital children are mixed due to the difference in duration of deafness. If we look at the age distribution, we can say that under the age of 4, results can be quite okay. Between 4 and 5, very mixed results, poor results in the older children. And it takes time for these children to get to these results. And that again brings me back to the point earlier is better. So we need an intensive counseling in these children, in the parents, especially also in the group of CMV, where we have a risk of losing the second ear. It makes it much easier, actually, in the counseling process. So what are my conclusions in children? The average age has decreased since we started the program. Still, they are older than the regular cochlear implant children. It is important to know that cochlear implant candidacy shows us, or evaluation shows us, 50% of cochlear nerve deficiency. So 50% do not qualify. And for this reason, MRI is a first-line examination in these kids. Before we start evaluation, before we start counseling about cochlear implants, the first thing we want to have is an MRI. So we kind of exclude these patients already, and they never heard about a cochlear implant. And I think it's totally important to first of all know more about the etiology and then to proceed to a cochlear implant evaluation. So MRI is a first-line diagnostic tool in these kids. It is important also to know that when we look over time, over several years, that for the younger kids, age 2 or 3, they have still a learning curve, there's still improvement over time. So even if we do it at age 2 or 3, there is improvement, but it takes it takes just more time than when compared to implantation at a younger age. Interestingly, we also looked for the subjective outcome, and this is also showing that we have big advantages for the kids implanted under the age of 3, and there is some increase over time, but not for those being implanted quite late. There's no real benefit, even if they have a little bit of speech understanding. The SSQ, the questionnaires show us that there's not a real benefit for the kids as well as for the parents. So I'd like to ask for a reduction of delay in implanting these children, because even if I do it in a late age, these kids will not have a long-term benefit. And this is important to know. Best rehabilitation results from our cohort, from our group of kids, is implanted under the age of 4, obviously, but older children could be candidates after the counseling. But again, look back at the data from Karen Gordon, for example, and others that showed us how important early implantation is, and why should be the maturation of the auditory pathway different in congenital deafness, unilateral deafness, and in bilateral. So there are so many processes going on within the first year of life that these kids should receive an implant at the age of up to 12 months.
Dear doctor, your time is up.
And I would like to thank you for bearing with me. And I would like to state that cochlear implants and single-sided deafness are a common treatment modality, and they're becoming a common treatment modality also in children. There's a need for rehabilitation and good counseling. We have to take into account cochlear nerve deficiency and CMV, especially in these children. And cross and bone-anchored hearing systems are second-line treatment possibilities in these cases. Thank you very much. Shukran.